Hi, my name is Randy Curtis, and I'm the director of the Cambia Palliative Care Center of Excellence. And I'm going to talk about medical futility. I was asked to talk a little bit about medical futility as part of this course. And so I'm going to use a recent multi-society statement about this topic as sort of the basis for my talk. Let's see. So medical futility has been a contentious topic for a number of years, decades actually, and the history of it is kind of interesting. And I'm going to go a little bit through some of the history of medical futility in modern medicine, and then talk about this new multi-professional society statement on this topic. Medical futility was first defined within the medical literature by Larry Schneiderman, Nancy Jecker, and Al Johnson from the University of Washington here. It has, they defined it in both in terms of quantitative futility and qualitative futility. Quantitative futility was, they argued that something was futile if in the last 100 cases the treatment had been useless, and qualitative as merely preserving permanent unconsciousness or failing to end total dependence on intensive medical care. This definition, I think, received a lot of attention. It was published in the Annals of Internal Medicine in 1990, but it also received a lot of criticisms. And there have been a number of articles that have argued that futility is not a useful term. Articles like Pulling the Plug on Futility or The Rise and Fall of the Futility Movement. And they argued these arguments were made from a number of different perspectives, and we'll go through some of them. But I think one question is this an important issue? And I would argue that it is, that the frequency and costs of treatments that are perceived to be futile, at least in critical care, is significant. In this study from UCLA, 11% of patients were perceived to be receiving futile treatment by ICU physicians and nurses. And they found that over $2.6 million had been spent in just 3 months in one ICU on treatments that were perceived to be futile. There have also been studies from Europe. This is not just a North American issue. In this study published in JAMA in 2011, 16% of clinicians judged that at least one patient under their care was receiving what they call disproportionately aggressive treatment, given the prognosis, a definition that some have used for futility. There's also a number of articles and studies that have shown that conflict about end-of-life care and potentially futile treatments causes moral distress in ICU clinicians. This is another reason why I think this is an important issue to understand and to be able to define and talk about. So what are the criticisms? What are the problems with medical futility? The first problem is that it's really often not straightforward technical judgment that are used in arguing that a case is futile. That in fact, it's exceedingly rare for surrogates and ICUs to request treatments that are strictly futile, that is, no chance of achieving their intended goal. And these cases often hinge on controversial value judgments. This is the study from UCLA that showed that perceived futile treatment was common, and the criteria that these clinicians used can be problematic. Things like burdens grossly outweighing the benefits, patient will never survive outside an ICU, which I think can be a very hard thing to predict, or simply that a patient is permanently unconscious as the definition of futility. So these declarations can be problematic, and they are often based on value judgments. And this is Ezekiel Manuel's publication in Hastings Center report in 1987, talking about the different values for the question of whether a life is worth living. And some of these values, I think, may be more common: hedonistic, that life's value is having more pleasure than pain; affective, that life's value arises from human interaction and emotional relationships, and autonomy, that life's value actually derives from the ability to self-determine. But this first one, the vitalist, that is, life is precious in any form, and value can be measured in milliseconds with a beating heart of a patient on a ventilator and unconscious. That's not terribly common, but it is a perspective that's held by some people in our society. And if that's the perspective, or that's the values used to determine whether a treatment is futile, you obviously get very different answers than some of these other values. So there are a number of relevant competing ethical considerations in assessing futility. That patients' interest in living according to their values and preferences is one. A second is that clinicians have an interest in acting in accord with their professional integrity. That's also important. And then finally, society's interest in just allocation of resources. And these values and ethical considerations can compete at times. The second problem is the limits of our ability to prognosticate. This is a study from 2011, the same study I showed earlier. And in this case, physicians, ICU physicians and nurses were asked to say whether they thought care was disproportionate. In 85% of cases, there was disagreement within the clinical team about whether the treatment was appropriate. And so there's obviously problems if we don't even agree on prognosis. And here's a study that showed that approximately 15% of patients who were determined by multiple clinicians as being very likely to die actually survived. And so I think that this is another issue that I think challenges medical futility as a concept. And so this statement that I mentioned was published in 2015, an official statement of a number of different critical care societies talking about responding to requests for potentially inappropriate treatments in the ICU. And there were three main groups of recommendations that came out of this statement that I think are interesting. The first is in preventing intractable disputes between clinicians and surrogates. The second is around terminology to describe these disputes. And then the third is resolving intractable disputes. The guiding considerations of the policy were the following: that it's impossible to create a policy that's free of value judgments, that clinicians should not make decisions unilaterally, but should also not acquiesce to requests that they believe harmful to patients or that violate professional integrity. And that a process of decision-making should satisfy the basic aspects of procedural fairness. So the first recommendation is that institutions should implement strategies to prevent intractable treatment conflicts. And these include proactive communication strategies with patients if they're able, and often in the ICU with surrogates, as well as early involvement of expert consultants. And the rationale for this is that it's much easier to prevent major conflicts than to manage them once parties are entrenched in their positions. It's also important to realize that not all conflicts are intractable. Some degree of clinician-family conflict is common and in fact should be expected. And some studies suggest that as many as 50% of deaths in the ICU conflict arises. And we shouldn't conflate any conflict with intractable conflict, because the tools to manage these things are obviously very different. This is data from a couple of different studies looking at unresolved conflict and resolved conflict, and just making the case that at a first family meeting in the ICU, conflict is common, but it's generally resolved within 2, 3, or more family meetings. So if the goal is to prevent low-level conflict from becoming intractable conflict, how do we do that? Intervening early, I think, is a key step. And that can include things like system-level proactive communication trainings and strategies to try to improve our communication with patients and families, providing advanced communication skills for providers, and then encouraging expert consultants. And this is a setting and a context where palliative care consultants can be particularly helpful as experts in communication, and can help, when conflict arises, help prevent it from becoming intractable conflict. ethics consultations are often very helpful. And within the UW medicine hospitals, we often find that we use both. Palliative care generally gets called earlier, and if conflict persists, ethics sometimes gets involved as well. And using the two together, in my experience, can be very helpful. So the second recommendation is around terminology and differentiating potentially inappropriate treatments and futile treatments. And so this statement argues that potentially inappropriate treatments is a term that should be used to describe treatments that have at least some chance of accomplishing an effect sought by a patient or their family, but that clinicians believe that competing ethical considerations justify not providing these treatments. The example in this statement is the ongoing use of life support in a patient who has metastatic cancer and progressive multi-organ failure not responding to treatment. That's the setting in which many people use the term futile, and this statement argues that we really shouldn't use that term, and that we should use futile only when we're describing an intervention that simply cannot accomplish the intended goal, often physiologic, of the treatment. And the example in this statement, which I personally don't find very helpful, is CPR in a patient with livedo reticularis and rigor mortis. I've never seen that in my clinical practice, but I think there are clearly some situations where the treatment can't provide the intended goal, and that we should use the term futile in those situations. So why use this term potentially inappropriate treatment? This group argued that the word potentially signifies that the judgments are preliminary rather than final and need verification. And the word inappropriate conveys that the assertion is being made by clinicians is value-laden rather than technical. And the idea here is this actually promotes rather than cuts off discussion and communication. The third recommendation had a couple of different components, and it was around managing requests for potentially inappropriate treatment when they arise. And intractable conflicts regarding potentially inappropriate treatments can occur despite intensive communication. And if they do, they should be managed by a fair process of conflict resolution. That includes hospital review, attempts to find a willing provider at another institution, which can be very difficult, but I think the process of making those attempts can sometimes help families come to terms with the reality of the situation. And then the opportunity for external review of decisions that are made. I think if you think about these three options for approaching intractable conflict, one is to give patients and families all authority. The second is to give physicians all authority. And the third is to pursue this kind of procedural dispute resolution strategy that's fair to both parties. And there are real problems. I think it's ethically unsustainable to say patients or families have all authority. This confuses positive and negative rights. Patients' rights to demand or families' rights to demand treatment is far weaker than their rights to refuse treatment. It also ignores the ethical importance of respecting clinicians' professional integrity, and it can result in unfair distribution of scarce resources. It's also ethically problematic to give clinicians all authority. There are risks. This risks unwarranted variability and arbitrary decisions from clinician to clinician. It's inconsistent with democratic ideals for fairly resolved conflicts about fundamental interests, and it disincentivizes finding a negotiated agreement. And so if deep disagreement about important interests are at stake, then the process of how decision-making occurs takes on ethical importance, and this group argues that should include oversight by a legitimate body, transparency and accountability, and the opportunity for review and appeal. One issue that came up and that this statement addresses is that sometimes managing these requests for potentially inappropriate treatments occurs in time-pressured situations, and it may be infeasible to complete all these steps of conflict resolution. In that situation, if clinicians also have a high degree of certainty that the requested treatment is outside accepted practice, this statement argues that we should try to achieve as much procedural oversight as the situation allows, but if there's agreement amongst the clinical team and the procedural oversight that is possible in the time-pressured situation, that we should refuse to provide requested treatment, and that all such cases should undergo prompt retrospective review by the hospital. And then finally, the third part of this recommendation is managing requests for what is truly physiologically fetal interventions. And the statement argues we should not provide physiologically fetal interventions and should explain carefully the rationale for not providing those. That if disagreements persist, that we should obtain expert consultation to help with conflict resolution, communication, as well as support of the patient or family, and that we should review all these cases. So what are the implications of this for our practice here at UW Medicine? I think that this is consistent with the way we practice, and I think we do need to continue education to prevent, identify, and address conflict early. I think that there should be education about the use of these terms, potentially inappropriate treatment versus futile treatment. In my experience, the term futility or futile intervention is used a lot in situations that it really probably shouldn't be. I also think that improved access to palliative care consultation is an important part of this as well, and that palliative care can be an important part of the solution for preventing intractable conflict, as well as managing intractable conflict when it arises. And we also need to make sure that we have in place a conflict resolution process that includes ethics consultation and a process to help families with this seeking referrals. So that's my summary of the ways to think about futility and potentially inappropriate treatment, and to think about opportunities to improve communication and conflict resolution when they arise. So thank you very much for your attention.